On behalf of the Centers for Medicare and Medicaid Services Division of Tribal Affairs, in collaboration with the CMS Medicaid Benefits and Health Programs Group, I would like to welcome everyone to an All Tribes webinar. My name is Nicole Pino and I work for Kaufman and Associates. I'll be your moderator today. Today's webinar is titled Medicaid Home and Community-Based Services. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenter and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. At this time, I will turn it over to Beverly Lofton.
Thank you, Nicole. Thank you so much. Good afternoon. I am Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs here at CMS. So welcome to today's webinar. This webinar is in collaboration with the CMS Division of Tribal Affairs and the CMS Medicaid Benefits and Health Programs Group. During today's webinar, our presenters will describe how CMS is proposing to establish a strategy for oversight, monitoring, quality assurance, and quality improvement for home and community-based services programs, also known as HCBS, and discuss other important proposed policies related to the HBCS. In addition, presenters will go over family caregiving reimbursement flexibilities that will be continued after the public health emergency. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website, and that is found at go.cms.gov/AIAN, and a web link will be provided in the chat. We are pleased to be joined on this webinar by Mary Botticelli and Melissa Harris from the CMS Medicaid Benefits and Health Program Group. I'm going to start it off by handing it over to Mary.
Hello, everyone. I'm Mary Botticelli. I am a health insurance specialist in the Division of Community Systems Transformation, which is a part of the Medicaid Benefit and Health Programs Group in the Centers for Medicaid and Medicaid Services. And today I'm also joined here with my CMS colleague, Ann Blackfield. Ann, do you want to introduce yourself?
Hi, everyone. Thanks for the introduction, Mary. Said I'm supporting Mary in this presentation, but definitely defer to her experience on this.
Thank you for inviting me to provide an overview of the home and community-based provisions in the Ensuring Access to Medicaid Services Proposed Rule, or the Access Proposed Rule as we may refer to it. And next slide, please. CMS released 2 notices of proposed rulemaking, the Ensuring Access to Medicaid Services that I just talked about, and also a proposed rule related to managed care access, finance, and quality on April 27th, 2023. If these proposed rules are adopted, they would establish national standards for access to care, regardless of where that care is provided, either through managed care plans or directly by states that have fee-for-service. It includes national maximum standards for appointment wait times for Medicaid and Children's Health Insurance Program managed care enrollees, rate transparency for fee-for-service and managed care, timeliness of access measures for home and community-based services, and secret shopper surveys for Medicaid or Children's Health Insurance Program managed care plans. Within both the rules, there's a range of effective dates across the proposed rules, from 60 days to 4 years from the publication of the final rules, with proposed stratification of certain home and community-based quality measures phased in over 7 years. In terms of the background related to CMS's access strategy, Medicaid and CHIP, otherwise the Children's Health Insurance Program, is essential health coverage for over 86 million people. So from a CMS perspective, it's vital that we consider ways to ensure access for our beneficiaries. Medicaid pays for 41% of all births in the United States, and it's the largest payer of long-term services and supports, as well as the largest single payer of substance use disorder treatment and mental health services. We also know that Medicaid beneficiaries who access their health care services using managed care and fee-for-service delivery systems, and we want to propose regulations that look across both of those delivery systems. In order to do that, CMS set 2 goals to improve and strengthen Medicaid and the Children's Health Insurance Program that reflect all aspects of access, getting people into coverage and getting people access to care once they're covered. We want to remove barriers for eligible people when enrolling and maintaining coverage and ensure equitable access to Medicaid covered health care services and supports. And so in these 3 boxes here, the eligibility and enrollment, that's before folks are enrolling in Medicaid, and while folks are enrolling in Medicaid, that was a proposed rule in 2023. Today we'll be talking about the ensuring access to Medicaid services proposed rule, the home and community-based services provision, and as well, there's a managed care proposed rule that I talked about earlier. In terms of background related to the home and community-based service provisions, we discussed in the preamble of the access proposed rule that they focus on specific challenges related to home and community-based services, including first, that there are workforce shortages, which are reducing access to service and are expecting to worsen in the future. Second, variation within and across states' incident management systems, which can result in a lack of oversight and intervention to prevent reoccurrence of negative outcomes for beneficiaries. And finally, gaps in measurement and reporting hamper efforts of CMS and states in assessing and improving the HCBS quality and outcomes and addressing racial and other disparities. In terms of the proposed rules related to home and community-based services and the access proposed rule, first, we propose a new strategy for oversight monitoring, quality assurance, and quality improvement for HCBS programs, as Beverly mentioned. With certain exceptions, those proposed requirements would apply to home and community-based services under sections 1915 1950C, I, J, and K federal authorities, and to home and community-based services delivered under both fee-for-service and managed care. We are proposing to establish new reporting requirements and minimum performance standards related to person-centered planning and incident management systems in HCBS, including that states have an electronic incident management system. We are proposing to require states to establish grievance or complaint systems in fee-for-service home and community-based programs to ensure that those Medicaid beneficiaries receiving home and community-based services through fee-for-service have the same opportunities as people enrolled in managed care plans and the managed care delivery system to file complaints related to the state or provider's compliance with person-centered planning and service plan requirements, and with the HCBS settings requirements. Next, related to payment rates and compensation for direct care workers, we are proposing to require that at least 80% of Medicaid payments for personal care, homemaker, and home health aid services, that be spent on compensation for direct care work for the direct care workforce, as opposed to any administrative overhead or profit. And we are also proposing that for each of those services, that states report annually on the percent of payments that are spent on compensation for the direct care workforce, and to separately report on those percentages for self-directed services. In addition, in the fee-for-service provisions related to rate transparency in the proposed rule, we propose to require states publish the average hourly rate paid for personal care, home health aid, and home homemaker services every 2 years, and states establish an advisory group for interested parties that would meet at least every 2 years to advise and consult on provider payment rates for personal care, home health, and homemaker services. We are proposing to require states to report annually on waiting lists in Section 1915C waiver programs, annually on access to personal care, homemaker, and home health aid services, and every other year on a standardized set of home and community-based quality measures. This includes phased-in requirements for states to stratify their data for certain measures by demographic and other factors in order to assess disparities and advance health equity. States would also be required to set performance targets for measures in the measure set and describe the quality improvement strategies that they will pursue to achieve the performance targets. The proposed rule identifies that measures included in the measure set will be identified by December 31st, 2025, and to update the measure set every other year after that. If the rule is finalized, this will be done in consultation with interested parties and through a public comment process included in the Federal Register. Finally, we are proposing to promote public transparency by requiring states to publicly report the quality, the performance, and the compliance data that they would report to us. And CMS would also publicly report the data and information across all states. In the access proposed rule, we request comment on a number of different things related to HCBS provisions. Among other things, these include effective dates of each provision, alternative thresholds where a minimum threshold is proposed, the time frame for reporting, whether the proposed requirements should also apply to certain 1905A state plan services, and where we have proposed applying the requirement to specific services, whether the proposed requirement should apply to certain other services. There are summary fact sheets for the access proposed rule on Medicaid.gov, and please note they're at Medicaid.gov/Medicaid access care. Comments on this proposed rule and actually the managed care proposed rule must be submitted by July 3rd, 2023. Now I'd like to turn it over to Melissa Harris, also from CMCS, to discuss the paid family caregiver options.
Thanks so much, Mary. And I'm really happy to be with you all today. My name is Melissa Harris, and I am a Deputy Director in the Medicaid Benefits and Health Programs Group. And I'm also doing a temporary stint as the Acting Director of the Division of Long-Term Services and Supports. The next several slides that I'm going to walk through are a repeat of slides that CMS used in a recent all-state call, where Medicaid directors from all over the country and Medicaid staff from all over the country were listening. And so you'll see a lot of this information geared towards states. And as we go through, I'll make some periodic reminders that states would need to determine to take these actions and then bring submit some actions to CMS. So in a nutshell, one of the flexibilities that states have used during the public health emergency in the name of making home and community-based services available in different ways during the PHE was to use legally responsible individuals, like a parent of a minor child, to be a paid caregiver. Normally, this was of a service like personal care, where the activity would be to provide assistance with bathing, eating, toileting, dressing, etc. And so the states could say in actions filed with CMS during the public health emergency that parents were going to be providers of Medicaid personal care services and receive payment directly from the state as those providers. We are making sure states are aware, now that the public health emergency has ended, that there continues to be pathways for these individuals, these parents, for example, to continue to be providers of Medicaid services. And given the ongoing workforce shortages in the direct service worker workforce, CMS is really encouraging states to think hard about how parents, as paid caregivers of personal care, can continue to play a role in the delivery of home and community-based services. So as happens so many times, the conversation with states needs to take into account the various authorities in the Social Security Act, Title 19 of the Social Security Act, that a state might be using to authorize a particular service. And in this case, a service like personal care shows up in a lot of different places. So the next couple of slides will walk through these authorities and walk through the different pathways available to continue paying parents now that the public health emergency is over. So the first authority that I'll highlight is under 1905A of the Act. These are the more traditional Medicaid benefits, the benefits that make up the EPSDT coverage mandate. And one of those benefits is personal care. There is a statutory prohibition written into 1905A that prohibits family members from delivering personal care services. Under the public health emergency, states were able to use the 1135 authority to receive Medicaid payment for personal care services when they were delivered by a legally responsible individual, such as a parent. That 1135 flexibility expired on May 11th with the end of the PHE. And so states who were reliant on that authority need to look at another pathway if they want to continue using parents as paid caregivers. There are a couple of other authorities that states have been relying on to authorize personal care services. Two of them are here. They're the 1915C Home and Community-Based Services Waiver and the 1915I HCBS State Plan option. There is no statutory prohibition in either of these authorities against parents being paid caregivers. And so even though we are now outside of the public health emergency, there remains an opportunity to move forward. What states were doing during the public health emergency was using Appendix K authority and disaster relief state plan authority to very quickly authorize parents to be providing personal care services in a way that they had not been in their Medicaid programs pre-COVID. But again, as we'll discuss in a minute, there is an ability for states to continue using parents as paid caregivers under these authorities. So again, we're now on the other side of the public health emergency declaration. And so some of the PHE authorities have already expired. Some are on the tail end. And so where does a state go from here? If they stood up something very quickly during the PHE to use parents as paid caregivers and the state wants to continue that. So for states that were using 1135 flexibility for 1905A personal care, that authority is now gone. That 1135 authority is now gone. And so states that want to continue to bill for personal care services provided by paid parents under the 1905A menu need to rely on a service other than personal care. And you see here on this slide that what we're advising states to do is to rely on the home health benefit. This is a mandatory benefit, and one of its components is home health aid services, which are pretty similar to personal care services. They both have a focus of providing assistance with activities of daily living, like bathing, eating, toileting, etc. There is no statutory prohibition under home health for allowing parents to be paid caregivers. And so states could bill for these services under the home health benefit as long as the parent has some sort of employment relationship with the home health agency. Home health is a service that is offered under both Medicare and Medicaid. There are conditions of participation for home health agencies. All the reimbursement for home health services goes to home health agencies. And so it's the agencies that have to be at the forefront of delivering home health services to beneficiaries. And so if a state wants to continue to use parents to provide home health aid services, those parents need to be employed by a home health agency. It's a little bit clunky, but not impossible. And we have some states that are pursuing that. For states that were using the 1915C or 1915I authority during the PHE, the runway is pretty clear for states to continue to use those authorities to continue offering paid or continue to reimburse parents as paid caregivers. States just need to explain to CMS that what the parents are being reimbursed to deliver is, quote, extraordinary care, which really only means that it's services provided above and beyond services that a parent would ordinarily be providing to a child of the same age without a disability. So again, it's just this extra services that a disabled child needs. It's that kind of service that a parent can be reimbursed for under these two authorities. There's a couple of other HCBS authorities on this slide and the next slide. I'll go through them just really quickly. If a state that you're in offers services under a 1915J self-directed option, this also can be used to authorize parents to be paid caregivers. And so states don't need any kind of special public health emergency authorization. They just need to have paperwork on file with CMS that they're using parents as providers. And the same thing goes for the benefit discussed on this slide, found in 1915K, also called the Community First Choice state plan option. Again, there's no statutory prohibition on parents being paid to deliver services. So at state option, states could file an amendment to their state plan to authorize parents to be paid caregivers under CFC. So states that are interested in pursuing additional flexibilities now that the PHE is over need to figure out the authority that they have their personal care services authorized under, and then work to get the right kind of paperwork submitted to CMS. And because we're outside of the PHE, all the typical submission timelines and expectations are back in effect for whatever kind of state plan amendment or waiver amendment a state is interested in submitting to us. This slide just reminds states that they need to take those timelines into account when figuring out when they need to get information to CMS. And so I'll wrap up by saying that some of you may be familiar with the 1115 demonstration authority. It's kind of an authority that allows a state to receive approval from CMS to implement their Medicaid program in a different way, in a way that's not typically authorized under Title 19. Many states have 1115 demonstrations up and running for a whole host of things. If a state has an 1115 and they are interested in using that authority as the pathway to continue to pay parents to deliver services authorized really under any of the benefit categories that I've walked through, we can have that conversation with states. And we just note here that states should contact us and their project officer to initiate those conversations. Okay, so right before I turn it over to a question and answer session, I'll reiterate that all of these flexibilities that I just walked through are at the option of the state Medicaid agency. And so we have received a fair amount of outreach directly from parents all across the country saying that they are, or had been during the PHE, had been receiving Medicaid payments to deliver personal care, and they were concerned about that authority ending now that the PHE is over. And in all cases, we have been referring those individuals back to the Medicaid agency because it is the state that needs to make the decision to continue to pay parents to deliver services now that the PHE is over. And it's the state that has to submit the right kind of paperwork to CMS to get that flexibility embedded into their programs moving forward now that the PHE has ended. So if you all, as stakeholders in your states, want to make your voices known to the Medicaid agency as they are making decisions about which flexibilities to continue, I would encourage you to do that. And with that, I'll stop and turn it back over for questions and answers. Thank you so much for having me.
So we do have a question here that did pop up from Geoffrey. How many states currently pay HCBS?
That's a great question. This is Melissa, and just let me put my video back on. So every state offers some array of home and community-based services. By far, the most popular vehicle or authority to do that is the 1915C Home and Community-Based Services Waiver. There are upwards of 250 of those operating in the country. And so that means obviously that states can have more than one. A state could have different waivers targeting different populations. So there could be a waiver for older adults, a waiver for adults with physical disabilities, a waiver for adults with developmental disabilities, traumatic brain injury, et cetera. And so that's the primary authority, but not the only one. States are using a mixture of all of those HCBS authorities that I just ran through in the slide deck. There are a couple of states who have all of their HCBS up and running under an 1115 demonstration. That's either because they have virtually their whole Medicaid program under an 1115, like the state of Arizona, or because over time they have consolidated all of their long-term care into an 1115. So every state has something under the offering of home and community-based services. It's just going to depend on what specific authorities the state has stood up. There's also a lot of variation in the scope and breadth of services that states cover under HCBS. The benefit packages that I walked through can authorize a whole lot of different things. From services that, again, are like personal care, services that are respite focused, services that are designed for community integration, the teaching of an individual new skills on how to be more independent, supported employment activities, housing supports, not rent and room and board, but housing supports. And so states, as you can imagine, approach that really flexible benefit package differently and offer different services under each of their programs. So it's really critical to understand the types of services that your state has available under the heading of HCBS. Thanks.
Great, thanks, Melissa. We do have another question again from Joffrey. What do home health agencies or COPS entail? And can a tribe be an HHA?
So I'll start off. This isn't exactly my area of expertise. There's a whole host of conditions of participation that are laid out, in the Medicare regulations, and those are those conditions of participation attached to a facility. So the home health agency, or I should say they attach to the home health agency as a provider. Some of them, not all home health agencies have a physical footprint. Some are a network of individuals who just go out to provide services in people's homes. But it includes things like the business operations of a provider, like who needs to be part of the ownership of the entity and the qualifications and functioning of that ownership. Then there's also some qualifications of individual healthcare professionals employed by those home health agencies, nurses delivering the home health nursing services. There are qualifications for training for home health aides, things like that. There's also requirements for the development of plans of care for individuals that are receiving the home health benefit. So it's worth taking a look at to understand what those conditions of participation look like. It's also worth stating that those COPs stretch across Medicare and Medicaid. And so most home health entities, not all, but most, participate in both programs. As to the question of whether a tribe can be a home health agency, I don't know the answer to that question off the top of my head. I don't know that there would be any prohibition on that, but the tribal entity would need to meet all of those conditions of participation and be able to document to the state and CMS that the tribe is compliant with all of those COPs.
Great, thanks, Melissa. And I think this next question will be for you again. So will states be required to consult with tribes before submitting their state plan amendments?
So I might, I'll start off and I might need some assistance from Beverly. So we are back under all of the traditional expectations for filing state plan amendments and 1915C waiver amendments. And so states are to be following their tribal consultation requirements as they've laid out in their filings with CMS. And so assuming that states have tribes in their state and fall under those tribal consultation expectations, they would need to be followed as the states are submitting post public health emergency submissions to CMS. But Beverly, I don't know if you want to add anything onto that.
Thanks, Melissa. Yes, you answered that absolutely correct. So as long as there are tribes in the states will typically consult with tribes when there's going to be new state plan amendments, for sure. So you answered that correctly. Thank you.
We had a question just come in from Joffrey. Does flexibility exist for states to propose tribal specific HCBS waivers?
Not under the construct of Title 19. The same kind of parameters attached to HCBS waivers as attached to state plan amendment provisions, for example. So just like a state couldn't have a tribal specific benefit stood up under the Medicaid state plan, a state couldn't have a 1915C HCBS waiver stood up just for tribal specific populations or tribal specific entities. But there are other ways, if there are particular topics that a state wants to be aware of, particular services, particular providers that are most meaningful to tribal populations, it's that kind of technical assistance that we would encourage a state to seek out from CMS so we can make sure those services and providers are featured with the correct amount of prominence in an HCBS waiver, but if there's not an ability to have one specifically targeted to those populations.
All right, so currently we don't have any additional questions. I will pass it to you, Beverly.
Thank you so much, Nicole. And again, I'd like to thank Melissa, Mary, and Ann for those remarks and just that wonderful presentation. It was very informative. I would like to thank everyone, all of the participants for joining today's webinar. And as always, if you want to submit any comments or inquiries to the CMS Division of Tribal Affairs, you can do that at our mailbox. And that mailbox is found at tribalaffairs@cms.hhs.gov. Again, that is tribalaffairs@cms.hhs.gov. And with that, thank you, everyone, and have a great afternoon.